Monika and Vidya, all of them said paper was okay. And, but some of the questions were like googly, not expected. So I thought we'll just discuss in this class those questions for the benefit of those who have written the paper as well as for the juniors who are going to face the exam in future. Because there is a possibility some of these questions which are mainly from the statistics and the research side of the syllabus, which we are not frequently discussing. So that may cause a little bit of confusion among the students. So I thought I will discuss them today so that it will be beneficial to all of you. Okay. So Kamachi, I will go straight away to my presentation.
Yes, sir. Yes, sir. Yes, please, sir.
So this question was the one which bowled many students. Okay? And the CONSORT guidelines standard, what are the guidelines for the CONSORT? So let it be an interactive session. Let me ask Risha, are you able to expand the acronym for CONSORT? Your answer?
During exam, I couldn't once you and I came to know it was a randomized control trial.
It is part of randomized control trial, but the actual expansion for CONSORT is this. It is a consolidated standards of reporting trials. Okay. So this is the expansion for CONSORT, consolidated standards of reporting trials. So whatever research trials you do, whether it is therapeutic or investigative, you have to send it in a proper format, like how you present your thesis to your submission as a part of your curriculum, where you first choose your topic, why you want to do that, you apply null hypothesis or alternate hypothesis, and then you plan your research subject. Then you choose a sample. Then for that you use a calculation how much of people you should examine. So the sample size is determined. Then you allocate them into groups, and then you think about the interventions that you want to do. Then observe the responses to the interventions what you do, and then you analyze the data that you get, and finally make a discussion and submit your thesis. That is the same way. So they have given that name, Consolidated Standards of Reporting Trials, for this particular methodology of doing the or presenting your trials. So it was developed to aid authors to present their randomized control trials in a clean, transparent, and complete manner for the assessment of the quality. And it has 25-item checklist, provides the author with a solid backbone to construct and present the randomized control trial. And it sets standards, trial designs, analysis, and interpretation of the results. So that is the idea of that, so that it is not just a namesake of research, but it should be in a very standardized manner, so that it is easy to analyze, and it is easy to give your opinion by the experts when you submit them for their response. So this is the flow chart given during 2010 as a CONSORT flow chart. So you first assess the eligibility of the patients or the subjects that you want to do that. And first stage is enrollment. And you exclude people who don't fit into the criteria that you want to keep for that. Then randomize them into groups. Either it may be a 2 groups, 3 groups, 4 groups, any number of groups, but it has to be randomized. That is called allocation. Then you do the interventions, and then that is called the follow-up. Finally, you do the analysis. So these are the 4 steps that they say: enrollment, allotment, follow-up, and analysis. And coming to the checklist, these are the 25 checklists that are given. The first one is having a subdivision of 1A and 1B. So the first and foremost is the title and abstract. This is what you normally send if you want to submit a paper to any conference or a journal. What you have to do is first you have to write the title and then give a short summary of what you are planning, so that the editors or the authorities who want to publish that will know a certain idea whether your work that you have done is worth publishing or not. So the first and foremost thing is the title and abstract. So identification as a randomized trial in title, and structure, summary, trial design, method, result. Some people give it as a small 1 paragraph abstract, but some people make it a subdivisions of the trial design, the methodology, the results, conclusions also in the abstract. So it can be submitted in both forms. It can be a simple 1 paragraph theme of what you are selecting, or it can be in the same design of this subdivisions. Then you go, when you submit the main paper or your trial, you have to go through first introduction, background and objective. Again, that is subdivided in 2A and 2B, where you have a scientific background explanation of the rationale and scientific objectives or hypothesis. Then when you come to methodology, it has a trial design, which is again submitted into 3A and 3B. Description of the trial as parallel or factorial, including allocation ratio, whether it is blinded or not, and important changes to methods after trial commencement, eligibility criteria, etc. Then the next part of it is participation. Again, that is divided into 4A and 4B, about the eligibility criteria of participants, settings and locations where the data were collected. Then comes the interventions. What is the actual therapy or the intervention that you do? It will be for each group with sufficient details to allow replication, including how and when they are actually administered. Then what is the result or outcome of that intervention? That is divided again into 6A and 6B. So it can be completely pre-specified primary or secondary outcome, or it can be any changes to trial outcomes after trial commence with reasons. If you want to halfway through change the protocol or do some changes, that also is accepted, provided you have a valid reason for that. And next is the 7th is the sample size. How was sample size determined? When application and explanation of any interim analysis and stopping guidelines are done. Then the sequence generation, it is again divided into 8A and 8B, and that method of random allocation or the details of restriction of anything that has been clearly mentioned in the sequence generation. Then allocation concealment, the mechanism of concealment mechanism, and implementation, who generated the sequence and how it was assigned, that also has to be explained. Then comes the blinding, where it is again divided into 11A and 11B. If done, who was blind after assignment to intervention, whether the participant or the care providers, that is the patient or the care provider or those assessing or reviewing that. So it may be single blind, double blind, or triple blind also sometimes. And if relevant, description of the similar to the interventions. Then comes the statistical methodology by which you assess. Again, that is divided into 12A and 12B. And finally, the results come. Participant flaw, a diagram is strongly recommended for results. And that is again divided into 2 halves. For each group, the number of participants who were randomly assigned received intended treatment and analyzed. are example for each group. Losses and exclusion after randomization together with the results have to be done. And recruitment dates defining the periods of recruitment and follow-up that has to be given the period of study. For example, you start your work in as soon as you are allotted the thesis. Say this batch who has joined in 2024. You are allocated your thesis in September 24, and you complete it in March 2025 or October 2025, that period of recruitment and follow-up. And if you have to abort or stop the thesis or your trial somewhere, then why you have stopped, that also has to be explained. And the next thing is the baseline data and the numbers analyzed, outcomes and estimation, and the ancillary analysis. All this come up to 18. And finally, any harms, allotment of harms to each group. Then lastly comes the discussion. In the discussion, it has to be in three parts, whether it is any limitations to your study or your work, that the trial that you did, and whether it is generalizability, external validity and applicability is there. These are all research jargons which you have to simply mug up. And but if you are going to full research, then you have to remember all these things. And when you come to the discussion stage of your thesis submission, you have to follow these guidelines or the checklist that you are allotted with. And finally, what is your interpretation? Which is whether it is consistent with the results, balancing benefits and harm, and considering other relevant evidence. So this is up to this is a very important checklist that you have to follow. Then finally, other information, registration number and name of the trial registry, protocol that was followed, full trial protocol to be assessed, and funding. Always you have to give lastly 2 certifications. One is whether you received any funding from any source for the trial, and whether there is any personal interest. Especially when you do a drug research, usually the pharmaceutical companies used to fund the research for their benefit. So if that is so, then there is a thing called bias. You may be doing the research right from the beginning with a biased attitude of promoting the drug and getting the drug marketed so that the company will benefit. So that is the reason why any funding is to be mentioned, which will give an idea whether you have a biased trial or not. So that ends the last checklist, and that is what I think you are expected to write on this particular question that has been there. I don't know how many of you could write all these things, but for the benefit of all the students, I thought I'll just present it this way. And the next important question, which bold you all, is the NDPS Act. Your other friends are there, Risha? Sanjuta or?
Just coming back from case.
Okay. Are they?
So they'll be joining.
Did you all discuss whether you wrote this answer to this after without referring to the books?
No, sir. Everyone wrote our own answers.
Your own answers, okay. But what is the reason you have to know about this Narcotic Drugs and Psychotropic Substances Act of 1985? Why, as an anesthesiologist, this topic has been included in our curriculum?
Sir, we should not possess or buy or transport drug in any form. It should be handled with a care. So we must be aware of it.
The first and foremost thing is it is available to us as a drug for treating patients. So the narcotics are the mainstay for pain relief, isn't it? From time immemorial, medicines, most of the physicians or surgeons, they don't have access to that. But as anesthesiologists, who are the main persons to relieve the pain of the patient, we are given the license to use these drugs freely, like morphine, pethidine, or the opium derived drugs naturally occurring or synthetic opioids. These drugs have been given license for the usage by the anesthesiologists because they have to use them for relief of pain to the patient. Okay, and there is always a potential to abuse the drug. Instead of using it for the patient, there is always a chance that and you know the addiction rate or abuse rate is very high among anesthesiologists because of this
I'm a
availability.
professional.
And
Yes,
and
sir.
among medical professionals, the surgeons and anesthetists have been only obstetricians. These are the three categories of people who have access to these narcotic substances, and the addiction potential has been identified as maximum among these three categories, and the anesthesiologists top the list even among these three people. So that is the reason why they want to people to be aware of this act so that they don't misuse it, and they should know what are all the punishments that can be received if someone abuses or misuses the power that they have to use this drug. And that is probably the reason why this act has been included. And any hospital which has the power to possess these drugs for patients' use, they can easily sell it to people who are addicted to these drugs, even among the public, and make extra money. Okay, they can sell it at a premium rate and make extra money. So that also will come under an illegal act of selling a narcotic drug. So that is why if you go to private hospitals, they all have to first of all obtain a license to possess the narcotic drugs like morphine or fentanyl if they want to use in their hospital. First of all, they have to apply to the revenue authorities and get the license, narcotic license, and they are supposed to maintain a register as to how many ampules or vials they procure every month, and what are the individual names and addresses of the patients in whom they used, and what was the indication, whether it is post-surgical or whether it is chronic pain. So whatever kind of indication that is there, that has to be mentioned, and in charge doctor has to certify and sign that register, and that register can be inspected and randomly it can be scrutinized by authorities. Without giving notice, they can come into the hospital and ask for the register and see whether it is being properly utilized to patient care without being diverted to for illegal purposes. So that is the reason why this question probably has been asked in your examination. So the act was the function. What is the reason? Was enacted by Indian Parliament in 1985 with the objective of consolidating and amending laws relating to narcotic drugs and psychotropic substances with some stringent control measures so that it is not abused. And they have defined some offences. What are the offences under this act? The act declares you should not produce any narcotic drug. Nowadays, we are seeing in the paper, even 10 days ago, there was an item in the Times of India newspaper that ex-DGP's son was trying to produce a synthetic addictive substance in his house with his friends. All of them are well qualified youngsters, all in their 23s and 24s. And they have set up a lab in their own house, and they have tried to manufacture some substance which will give some hallucination and euphoria, and that has been raided and they have arrested them. So production or manufacturing or possessing, selling, buying, transport, or consuming, importing, exporting. So these are all legal terminologies, not to give any loophole. So all these things are offense, and transiting narcotic drugs or psychotropic substances are defined as offense. And what is the punishment and penalty? It fixes severe punishment in the form of rigorous imprisonment with a heavy fine, and it can be very dangerous offense if somebody is caught with that particular offense or detected that they are in possession of unlawfully the narcotic or psychotropic substances. And the rehabilitation and treatment, these provisions include treatment and rehabilitation of drug addicts. So it is having a slightly sympathetic look towards the people who have already got addicted to the drug, and they are given rehabilitation and treatment with a health-based approach to parallel the as much as they want to punish the offenders who are habitual people and who do it with the purpose of earning money. They are different from people who unfortunately become addicts, who cannot get out of that habit. They have to be given some rehabilitation and treatment. And any act, when it is proclaimed for the first time, based on the practicalities, it will all be amended from time and again. So this includes updates to address new challenges such as misuse of prescription drugs and synthetic substances, as well as streamlining of procedures for both enforcement and adjudication. Then, what is the definition of a narcotic? A drug in moderate doses, it will dull the senses, it relieves pain and causes sleep. These are the functions of the drug, but in excess dosage causes stupor, coma, or convulsion. That is the definition of narcotic. The definition of a psychotropic substance is one that is capable of affecting the mood, emotion, and behavior. So this is the reason why many people use these substances for euphoria, elation, and all of you must have heard about party drugs nowadays. Even our ketamine, which is considered as one of the very important drugs in our armamentarium, that is used as a party drug or a euphoric drug and being misused. And India's policy towards this act is derived from Article 47 of the Constitution, which says that state shall endeavor to bring about the prohibition of the consumption of intoxicating drinks and drugs which are injurious to health, except for medical purposes. So if you are taking any narcotic, it should be only for medical reasons, to alleviate your pain and not for your entertainment purposes. Okay, that is the main reason for this act. And the major reason why they have not included alcohol in this, because alcohol also has got similar properties, but the reason why they have not included alcohol in this NDPS act is it has been accepted by social norms to be as a it is not in many parties it is all being accepted unless you overdo and produce trouble to other people. It is accepted norm even among the social gatherings, and it creates rich revenue for each state. That is the reason why Tamil Nadu is not keen on abolishing or closing the liquor shops, because it's a main revenue generator for the state. And if you close that legal supply of alcohol, there's a chance of illicit alcohol and locally brewed alcohol being distributed to the public, like what we had in Kalakurchi some months ago, where 60 to 70 people died of illicit alcohol drinking. So these three reasons have made the policymakers not to include alcohol under this drug, and only the narcotic and psychotropic drugs. Now, there are some terms which you have to remember and how they have been given with regard to the narcotic substances. In 1961, they had what is called a single convention on narcotic drugs, and they scheduled the drugs into the 4 categories. And the first scheduled drug is a substance which is highly addictive and has an abuse or unworkable potential. The second is less addictive. Second drugs coming under Schedule 2 are less addictive. Schedule 3 are intended mainly for medical use. So most of the drugs like morphine, fentanyl, all the drugs that we use, they are all coming under Schedule 3 of the Narcotic Act. And the Schedule 4 is certain drugs which are linked to highly addictive and liable to cause abuse and rarely used in medical practice. This will cause, under this category only you will get all the heroin, the ganja and other things. They are, even though they are called drugs, they are all substances, narcotic substances. And then Schedule 5 is their low potential for abuse with relative to substance listed. Oh, sorry, I am at the 6th schedules. And 6 is consistent primarily of preparations containing limited quantities of certain narcotics. So, possession, selling, or abusing any of these drugs is a punishable offense that we have to know. And some of the common drugs that we use in anesthesia, under what category it comes, we have to know. Cocaine, which we are not using anymore, comes under Schedule 1, which is a highly addictive drug. And codeine comes under Schedule 2, it's less addictive. I don't know how many of you are aware that most of the cough syrups in those days used to contain codeine. So people used to take codeine as a regular sleeping drug in the night, even if they don't have a cough. So that is the reason why now codeine has been banned from inclusion into the components of cough syrup. Then clonazepam, which is benzyl, what is that?
Benzodiazepines.
Benzodiazepines, sorry. The clonazepam is coming under Schedule 4. So it also has an addictive, but it is quite commonly used under some physicians commonly prescribe that. Diazepam also comes under. That is why once people get hooked to your Restil or Alprax or diazepam, they will always say, if I don't take that drug, I can't go to sleep. That will be the history that you will be getting from some elderly people. And ephedrine also, it's a mood elevator. It comes under Table 1, which I will be showing again in a different category. And fentanyl comes under Schedule 1, highly addictive drug. Lorazepam comes under again benzodiazepam class 4. Methadone and midazolam comes under again class 4 Schedule 4 of the drugs. Morphine comes under Schedule 1, highly addictive. Oxycodone, which is also a part of narcotic, comes under 1. Phenobarbital comes under Schedule 4, and remifentanil comes under Schedule 1, and sufentanil comes under Schedule 1. So all those substances, even though we are using them for medical purposes, and that is the reason why these drugs are given without properly analyzing whether the patient has been now pain-free or not. Prescribing them regularly makes the potential chance of the patient becoming addicted to that, and they will start feeling and complaining of pain to get the drug simply because it gives them good euphoria and sleep. So the narcotics should not be unnecessarily misused during treatment of a patient, which has the potential to make them become addicted to the drug. So the expansion for this NDPS is a Convention Against Illicit Traffic in Narcotic Drugs. CPS is the Convention on Psychotropic Substances. SCND is the Single Convention on Narcotic Drugs. That is the 1961 Single Convention. This is the categorization that is done according to this. Then later on, as I told you, there was an amendment going on. So in 1971, after 10 years of the first convention, there was a second convention to amend the rules based on the usage of psychotropic substances. And in Schedule 1, substances that present a high risk of abuse, force, or particular serious threat are very little or no therapeutic value is being included in this first schedule. Schedule 2 has a risk of abuse. Earlier I showed you first the schedule is a very highly addictive drugs or the substances. Here it is less addictive in Schedule 2, the same thing, but it can pose a serious threat to the public health and some therapeutic value. Schedule 3, substances that present risk of abuse, pose a serious threat to the public and are of moderate therapeutic value. Then Schedule 4 risk of abuse, minor threat to public, and have high value for treating the people. Then came another, so from sixth schedule in 1961, they reduced the schedule into just 4 categories. So that is the reason why I initially said there are 4 schedules. So that is the present one. And in 1988, the Convention Against Illicit Traffic and Narcotic Drugs was introduced, where they introduced the tables. Table 1 is the precursors of psychotropic substances, key reagents used in conversion and extraction of narcotic drugs and psychotropic substances. Table 2 contained reagents and solvents that can be used in the illicit production of narcotic drugs and psychotropic substances, but also have widespread industrial uses. So chemicals that are used in the industry, in the example I told you, which came in Times of India, the youngsters who wanted to prepare their own narcotic substances, they used all chemicals that are used in the industry, which are available without any restriction. And that is how they made. So they made these 2 tables of substances. Then anesthesia is uniquely affected by national and international drug control law, where 15 of the 46 anesthesia and analgesia related essential medicine listed in the categories of anesthetics are medicines for pain and palliative relief or anticonvulsants or anti-epileptics, all of which have some crossover into clinical anesthesia, are being brought under international control through one of the 3 drug control conventions. So 1961 convention, 1971 convention, and 1988 convention. Among these 3 conventions, all our 15 out of the 46 drugs that we use, they all come under these 3 conventions. And that is the reason why probably this question has been asked. The important to recognize that restrictions resulting from national and international controls, that is the scheduled drug, you cannot just get it without a proper prescription or without the authority of a hospital. Nowadays, you know, you go to pharmacy, you get any antibiotic without doctor's prescription by just asking if you know the name, the pharmacy fellow will give you. Whereas in the Western countries, except for paracetamol and ibuprofen, or some antihistamine, you cannot get anything over the counter. So there, everything is a scheduled drug. Whereas here, because our drug controls are not being very stringently employed or followed up, we are able to get the drugs by just going and asking without a proper prescription from the doctor. But these scheduled drugs you cannot get even if you have a proper prescription. Majority of the pharmacy drugs, so people will not be free to give you because they are likely to be scrutinized and their license can be cancelled, because that's such a powerful act that, as I told you, possession, selling without proper license is an offense. So they will not be able to give you these drugs, scheduled drugs, even if you have a. So that is the reason why you have to get it in the same hospital where they have a proper license. And so this is the potential to produce harm, and the judicious and responsible use is very, very important for this. Nevertheless, these restrictions must be reasonable. So just because a hospital has not acquired a narcotic license and the power to possess this drug, you cannot deny the drug a patient, post-operative patient in severe pain, just because the hospital does not want the headache of possessing a narcotic license and keeping accounts and maintaining the register. They cannot deny the good pain relief that the patient will get by administration of a narcotic substance. So the act must have a good balancing act to do between preventing harm at the same time, not preventing the patient from enjoying the relief given by the drug. Okay, so that should be a very proper way to do that. So that is the reason why this NDPS Act has been observed, and in case Unfortunately, if the same question comes after 2 years, the juniors must be having an idea to write what they have to write about that. So this is what I thought I will just give you. And of course, this is the last week's discussion on pancreatic cancer. We'll just skip through that. Now, anesthesia and cancer recurrence. That was another question that was asked. I see Vidya's name here. Vidya, what did you write for this? Are you there, Vidya? Actually, the question was anesthetic implications in a patient with recurrent cancer. So the question can be worded in two ways. So I thought all of you must read the question properly if this question is asked. One is anesthesia as a cause of cancer recurrence is one part, or it can be patient with a recurrent cancer coming for a repeat surgery where anesthesia is needed. So it can be discussed in two ways, or a question can be framed in two ways. So what is the implication of anesthesia in producing a recurrence of cancer in a patient who is primarily undergoing treatment for cancer? That is one aspect. If the question is worded, patient with recurrent cancer coming for anesthesia, what are all the implications and challenges? Then that is a little different answer that you have to give. So what answer all of you wrote, I would like to know.
We just very generally, sir. A few agents, they can modulate the cytokine release and the immunity.
Very good.
Then the skin infiltration in cases, few onco cases can be we can be avoided. Like
post radiation, did you write about post radiation scarring and difficulty in airway management? Did you mention that?
No, sir. No, sir.
Because patients who come with a recurrent cancer after follow-up chemotherapy or radiotherapy after the initial surgery, they develop these complications. As you rightly said, chemo produces immunomodulation or immunosuppression, and patients are likely to have easy infection chances. Similarly, radiation also, and the effect of the chemotherapeutic agents on various systems like cardiac system can produce cardiac abnormalities, hepatic, renal abnormalities, and the myeloproliferative system can be completely suppressed with the patient having a low total count. And then the radiation problem like scarring and fibrosis, making the airway, neck movements difficult. All those things are things which you can discuss on patient with recurrent cancer coming for that. But if the question is worded, the effect of anesthesia on cancer recurrence, so I thought I will discuss both of them. So the first part is what is the implication of anesthesia in a patient, for example, a patient with breast cancer comes for a mastectomy. What are all the chances of this patient having a recurrence of the cancer because of the anesthetic that we use? That may be the one aspect of that. So the effect of anesthesia on cancer recurrence. So that can be several perioperative factors are responsible for dysregulation or suppression of immunity with the possible impact on cancer cell growth and development of new metastasis in the patient. What are those things? So anesthetic and analgesic used during perioperative period may modulate the innate and adaptable immunity, increase the inflammatory system activity. It can cause angiogenesis, new vessel formation, with the possible impact of cancer recurrence and outcome on that patient. There are several perioperative factors such as inflammatory response to surgery, hypothermia that happened during surgery, blood transfusions given, tissue hypoxia or hyperglycemia untreated, postoperative pain can create a state of relative immunosuppression, which can be the cause for patient developing a recurrence of cancer. Now, stress factors also have the potential of activating systemic inflammatory response and enhancing tumor growth with consequential increase in the risk of metastatic recurrence. Then opioids have immunosuppressive qualities, including reducing the activity of natural killer cells and neutrophils, which can accelerate cancer progression. So opioids can directly influence cancer cell growth, not only in the body, but in vitro through their effects on mu opioid receptor, which is overexpressed in a wide range of cancer cells. And that is the reason, including breast, colon, and lung cancers. So because these cancer cells have mu opioid receptors, usage of continuous usage of opioids in these patients are likely to produce a recurrence. And we, without realizing, we give them these drugs to alleviate the pain, saying that the cancer patient should not suffer from pain, and the opioids are the mainstay of our treatment. So this is one thing which you have to keep in mind, that usage of large opioids may pave the way for recurrence of cancer in a patient who has undergone surgery to clear the cancer of this body. Then potential tumor potentiating consequences of alpha-2 agonists, like we are using dexmedetomidine and clonidine as routinely for most of the cases, must be balanced against their secondary opioid and volatile anesthesia sparing effect in cancer surgery. So they have their own power to potentiate the tumor recurrence, but if you use them judiciously, it can help us to avoid too much of opioids. So in that way, alpha-2 agonist may be a drug which is a double-edged weapon. So you have to use it very carefully. So by itself, it can potentiate a recurrence, but if used carefully, it can prevent the usage of too much of opioids, which will definitely reduce the chances of recurrence. And total intravenous anesthesia is associated with recurrence-free survival. So for all cancer patients undergoing surgery, TIVA will be the best choice to reduce the chances of recurrence, because when we use narcotics or opioids and volatile anesthetic agents, the immunomodulatory system is very much affected, and the chances of a recurrence are very much high. Whereas TIVA has been proved to help in a recurrence-free survival compared to the other modes of anesthesia. And transfusion of blood because of intraoperative loss can cause inflammation and immunosuppression. So as far as possible, better to avoid transfusion by all methods of conservative management without transfusion, so that recurrence can be prevented. So these are all the things that you have to remember with regard to anesthesia, which can be a causative factor for cancer recurrence. And this is given in the WFSA article. What are all the pathways by which these actions are carried out? So the first and foremost is called the hypoxia-inducible factor 1A alpha, which results in angiogenesis, glycolysis, cell proliferation, and anesthetic agents which have been proved with the laboratory, the in vitro, that volatile increases this component or the pathway, and propofol decreases this pathway. That is why if you use TIVA, this will be helpful to the patient in reducing these chances. Then there is a second factor called insulin growth factor, which causes cell proliferation, suppression of apoptosis, and again volatiles increase this IGF. Then the third thing is epithelial growth factor receptor, which again causes cell proliferation, cell growth. Local anesthetic decrease that, and that is the advantage. Earlier it was thought that local infiltration will cause seedling deposits of cancer cells and recurrence will happen at that injection site. but now that has been disproved because they decrease the epithelial growth factor, which is responsible for cell proliferation. So you can safely use local anesthetics in cancer patients. And nuclear factor kappa, NFB, this causes suppression of apoptosis, chemo resistance, and the tumorigenesis. Again, local anesthetic decrease this factor also. Then vascular endothelial growth factor, which causes angiogenesis and tumor genesis. Opioids and volatile anesthetics increase. That is another mechanism by which opioids can cause a recurrence. And NSAID drugs and propofol, they reduce that. So instead of using opioids, you can use NSAIDs provided the renal function is normal. And then neutrophil transforming one gene, which has a cancer invasion and tumor invasion. Again, opioids increase that, propofol decreases that. And the natural killer cell, they cause lysis of tumor cells. Opioids, they decrease the activity of natural killer cells, making the to increase. And the steroids also decrease the NK cell activity. Then cytotoxic T lymphocyte directly eliminate tumor cells. Then volatiles decrease that, and volatiles again decrease this helper cells activity, which interfere with gamma and tumor necrosis factor and interleukin factors, all these things. So you can see this is the pathway, the mechanism how volatiles and opioids have the capacity to cause a recurrence, whereas the intravenous anesthetic agents like propofol and local anesthetic agents have the chances to prevent the recurrence, and the NSAIDs also. So this point you have to keep in mind and avoid as far as possible the usage of opioids and volatile and steroids to prevent the recurrence. Now coming to the other way this question can be framed, these anesthetic challenges in patients with recurrent cancer posted for surgery. Now, what is the preoperative assessment you have to do in these patients? A detailed drug history, a thorough examination are important to understand the patient's cancer management and specific toxic effects of the various drugs that have been given. Now, what type of anesthesia has been administered, whether it has been GA, which is linked to increased metastasis in animal studies, or neuraxial techniques, which have been preferable rather than to go for GA. Whether any volatile agents have been used and whether can be avoided to prevent cancer from preoperative immunosuppression, from what we saw in the earlier slide. And we must get a very detailed history about the chemotherapy they underwent. Chemotherapeutic drugs causes toxicities in the heart, lung, kidneys, liver, and bone marrow. Some chemotherapeutic agents like bleomycin cause pulmonary change, while others like anthracyclines can cause cardiac issues. Then chemotherapy can be two forms, which we saw in the last class. Priya, I think she mentioned correctly. Neoadjuvant, which is given before surgery to reduce the tumor size, and adjuvant chemotherapy given during and after surgery, and palliative chemotherapy given to improve just the quality of life without giving a full relief from the cancer. Then similarly, radiotherapy causes tissue damage through production of oxygen-free radicals. As a consequence, they can cause delayed wound healing, induration of the skin, vascular stenosis, myocarditis, pneumonitis, and pulmonary fibrosis. All these changes are possible with radiotherapy. And previous treatment with radiotherapy could also lead to limited neck extension and rigidity of the oropharyngeal tissues, especially after oral cancers. When you do a CHE resection with soft tissue excision and the reconstruction with a flap and all that, and post irradiation necrosis, fibrosis happens, and the patient may come for a recurrent lesion again in the same area. It will be very challenging to intubate the patient because of the changes that happen. So this makes ventilation with face mask and laryngoscopy difficult, So radiotherapy for head and neck leads to difficult central venous access also if you want the IJV cannulation. Mucositis as a consequence of radiotherapy can be exacerbated by tracheal intubation also. Now, the interval between the neoadjuvant therapy and surgery depends on the type of cancer. So, patients, if there is a gap or interval between these two treatments, then there may be chance tissues may be, all the toxicity may be quite less. So, a treatment plan aimed at choosing the best interval for surgery to avoid acute side effects of chemotherapy should be discussed with the oncologist in the pre-assessment stage itself. And for example, myelosuppression, coagulation disorders, renal or hepatic impairment, and anaphylactic reactions can develop unexpectedly. Regional anesthesia and analgesia may influence cancer recurrence. So, lidocaine and bupivacaine inhibit the transcription pathways associated with the initiation and metastasis of cancer with the decreased mesenchymal stem cell proliferation. So, as I showed in the earlier slide, local anesthetic and regional anesthesia produce less recurrence or help in further relapse. Use of regional anesthesia, especially thoracic epidural, has a variety of benefits for patients post-operatively. It improved analgesia as well as reduction of opioids associated side effects, inflammatory response and adrenergic response to increase circulating catecholamines, and factors believed to mediate post-op immune response suppression also are reduced. And regional anesthesia may increase the expression of several cytokines expressed perioperatively, like interleukin 4 and 10. And these are anti-inflammatory, which may directly attenuate the surgery-induced pro-inflammatory response and reduce the rate of post-operative complications. That is the mechanism by which regional techniques may promote anti-inflammatory cytokines, not pro-inflammatory cytokines, and also attenuate the pro-inflammatory response of the surgery. Alternatively, local anesthetics may directly stimulate natural killer cells activity, and these cells are important in destruction of tumor cells. And local anesthetics are suggested to have anti-proliferative and cytotoxic effects on the cancer cells. Whereas volatile agents, as we saw in the earlier thing, associate the immunomodulator, increase the ability for tumor metastasis, and the mechanism, they decrease the NK cell activity, interfere with lymphocytic antigen activity, and induction of T lymphocyte and B lymphocytes. And they can also have direct effect on cancer cells to proliferate. Now, this pharmacological management of cancer pain is very important as a part of the management of anesthesia for patient coming with a recurrence, because in the first primary surgery, if the patient has been given a lot of narcotics to alleviate the pain, and once the patient has suffered a recurrence and he is having some excruciating pain because of the recurrence, these patients are likely to be given a large doses of narcotics for pain relief, because that is considered as a B drug for cancer pain, and that we saw causes alteration in the immunosuppression in by itself causing the recurrence. And the other important factor is these patients become tuned or addicted to these drugs, number one, or they have developed tolerance. So their need for doses of drug will be very high. They may not respond well to the doses that we normally give, like 1 to 2 micrograms of fentanyl or 0.1 to 0.2 milligrams of morphine. That may not be sufficient for these patients. So you have to look into the angle of management of pain in these patients from a different perspective, like a patient who is addicted to narcotics. So what is the method described, or what is the recommendation for patients who have potential for or who are already known addicts of narcotics coming for surgery? What is the best way to relieve their post-operative pain if they have to undergo surgery? Any idea? Risha, Vidya, Sangeeta, Shobika, Saundarya.
You can go for
What is the
opioid treatments.
opioid free? What is the main drug that is recommended as an infusion? Giving you a clue also.
Remifentanil infusions.
So remifentanil is very short acting. Once you stop that, it is in the use only intraoperative phase, not for as a post-operative pain relief. I am asking about post-surgical pain, where a patient already addicted or have used to large doses of narcotics will not get adequate pain relief with the same use of morphine or Epidural. So what is the mechanism or what is the method of managing that? Ketamine infusion, okay, 0.1 to 0.2 milligram per kg of ketamine for the first 72 hours post-op relief as an infusion is the method of managing post-operative along with NSAIDs and regional blocks. Whatever facial plane block you can think of, that is the method of managing the pain. So that also is an important part of the challenges that you will face in a patient who comes for anesthesia with a cancer recurrence. Okay, so think of these 3 points. One is the chemotherapy, radiotherapy, usage of this morphine, and extensive use of local anesthetic and regional techniques in the current management of surgery, and idea about managing pain in a patient used to large doses of narcotics with ketamine infusion. Okay, these are all the points I think expected for this particular question. Now, there is another question called closed loop anesthesia delivery systems. Okay. Did you all write this question well? What is the answer that you wrote? Vidya, Sanjuta, Shobika. Say something. Or you have written the answer.
Anesthesia is administered to the patient based on their vital signs.
Okay.
The drug is delivered to the patient based on their.
First of all, what do you mean by closed loop anesthesia delivery system? Is it a mechanical thing, or it is a computerized system, or it is something like TIVA, or it is like
Computerized,
like
automatically it adjusts.
That is the first thing that you have to system that automatically adjusts the rate at which anesthesia is administered to patient based on real-time monitoring of their vital signs. What are all the vital signs that they have to monitor when a machine is going to administer anesthesia? What are all the things that the machine should know to maintain the correct anesthesia level?
The heart rate and the blood pressure.
That is hemodynamic monitoring. Okay. So just monitoring the heart rate and blood pressure, will the machine be able to give the drugs required to maintain anesthetic state?
The target depth of anesthesia.
The first and foremost is depth of anesthesia. Okay. So this monitoring is very, very important. That only tells you whether the patient is in the adequate plane of anesthesia. What is the value that is required? Is considered as clinical anesthesia. In this monitoring, 40 to 60, isn't it? So that monitor is a important component for closed loop anesthesia delivery system. So first and foremost, you must have a BIS monitoring to make sure that the machine knows that the patient is kept under proper plane of anesthesia. Second thing is, what are the three components of balanced anesthesia?
Anesthesia, amnesia, analgesia.
Analgesia, hypnosis or anesthesia, analgesia, and muscle relaxation. Okay. So how do you achieve analgesia? With narcotic or other drugs.
Yes.
How do you achieve muscle relaxation?
With depolarizing or non-depolarizing?
Muscular blocking agents. Okay, it can be non-depolarizer. initially depolarizing for intubation, but nowadays most of the people straight away go for non-depolarizers to even for intubation and maintain the muscle relaxed state using either intermittent bolus doses or continuous infusions to maintain the muscle relaxation. So these three things have to be fed into the machine, which is going to supply the drugs. Instead of you, nowadays what you are doing, you are first giving propofol as a bolus dose intravenously. You are following it up with a muscle relaxant. Then you are oxygenating the patient, pre-oxygenation, and during the time interval to achieve adequate muscle relaxations to secure the airway, you ventilate the patient with oxygen. Then you do a scopy or use a gadget to intubate the patient, secure the airway. Then you control the patient's ventilation using a volatile anesthetic agent, oxygen and air or oxygen nitrous oxide. And then intraoperatively, you administer analgesia at intervals and muscle relaxant at intervals. All these things are done manually by your observation of the patient's condition, like pulse rate, blood pressure, and adequacy of muscle relaxation in the operative field, or the surgeon's complaint whether they want more relaxation. Or so this is what you are nowadays routinely doing. All this job has to be done by a machine in closed loop anesthesia delivery system. So the machine takes over your place to determine when to give the analgesic, when to give the non-depolarizing muscle relaxant, and how to keep the anesthetic state between 40 and 60 of these by either intermittent infusion of propofol or whether to go for a volatile. All this is decided. So your job is done by a machine. That is what is called the closed loop anesthesia system. So for that, the machine has to get a feedback to decide whether we have to give additional relaxant now, whether we have to give additional analgesic now. So that is what is called the system. So that is what is expected out of this. So goals of class improve the quality of drug delivery and ensure personalized care. It has three main components. The system or the machine which is used for closed loop anesthesia, it has three main components. Can you name the components, Sanjita?
No
So
idea, sir.
okay, this is brain. The central, what your brain is replaced by the machine brain. Okay, central operating system, which contains built-in algorithms. So that is what is going to decide when to give the relaxant, when to give the analgesic, when to cut off the analgesic, when to cut off the volatile, depending upon the state of surgery. The second is affect a target control variable. What is the patient's blood pressure? What is the patient's pulse rate? What is the oxygen state? What is the carbon dioxide level? Everything is the effect. The third is actuator, a drug delivery system, like a syringe pump. So these are the three main components of a closed loop anesthesia system. A central brain system, just it is similar to our brain, what we are using by observing the patient or observing the monitor. But for that, instead of to make that brain work, we have to machine has already been fed with lot of algorithms to decide when to give instructions to utilize this actuator system. That is based on the variables that is fed into or the response that it gets into the brain. Okay. So these are the three important things. These three elements are connected by a feedback system, which allows automated control of drug delivery and maintain a preset target value of control variables without any manual input. So this is the very important thing. You don't do it intermittently like what you do in your day-to-day practice now. So everything is taken care by the machine. So if you see the picture here, this is the automated control system. So it receives data from this thing. There is a built-in algorithm control clearance. And this will give instructions to the drug delivery system, the infusion syringe pump, and the human body acquisition of general anesthetic related parameters. One is this parameter, second is CPMG, is and analgesic score, And then these things are given to the monitor module, which is again fed back into the automatic control system. So based on the patient's response, it will decide how much of analgesic to be given, how much of relaxant to be given, and all the instructions will be passed on to the drug infusion delivery system, where it will be automatically adjusted. So by frequent sampling of control variable, more frequent changes of drug delivery rather rates than manually done can be done. So there will be greater stability of the variables, which can be achieved easily by the accurate delivery of the drugs. And the, say for example, if you forget to give a dose of relaxant and you have been watching your WhatsApp and suddenly the patient becomes light, or there is a tightening, then the surgeon will yell at you. All these things can be avoided by this closed loop delivery, because it is closely watching all the changes in the patient and immediately adjust the dose. So there is no time lag at all in administrating the dose, and that is the first thing that said improved quality of drug delivery that is happening. And these three components of general anesthesia, like hypnosis, analgesia, and neuromuscular block, are taken care of. So this value is used as a control variable for closed loop system to deliver anesthetic drug, outperforming manual administration. So even when we are doing in our regular day-to-day anesthesia, all of us have encountered some situations where patient has become light, or relaxation has become inadequate, or analgesia has not been properly given, and there's a shoot up of blood pressure and heart rate. All these things we see in our day-to-day practice. All that can be avoided by using this flow fluid system. That is the purpose of this particular topic. Now the application of this class for opioid faces a problem. This is the only snag that we come across in this is because the optimal method to measure the intraoperative pain, where patient cannot do that, like in the postoperative pain, we have so many scoring systems to assess the pain. Whereas patient under anesthesia, it is not possible. So this is the only snag where we have to, the machine has to make a decision about the pain relief by indirect methods like rise in pulse rate, rise in blood pressure. So hemodynamic measurements have mostly been used as useful in administering opioids most of the time. And there is a novel score called analog low score using heart rate and arterial pressure, which was recently presented and successfully titrated to closed loop remifentanil administration. So that is how the system also is using the same parameters. And closed loop systems for various neuromuscular blocking agents have shown good performance. So again, usage of neuromuscular blocking, monitoring devices can help in proper administration of neuromuscular blocking drugs to maintain the required neuromuscular blockade for surgery. And patient monitoring and algorithmic pharmacology have led to better control over patient-specific biological reactors, because each patient will have a different response to the same drug. For example, a chronic alcoholic may require a more amount of induction agent as well as narcotics and analgesics, whereas a patient who is very thin-built, very teetotaler, may have exaggerated response to the normal body dose of the same narcotic and other drugs. So this is the algorithmic pharmacology has been formulated to have a patient-specific biological reactions to administration of drug, which even we can not do correctly. So that is the advantage of that. And there is a machine called Max Sleepy, which is a sort of humanoid anesthesiologist that thinks like anesthesiologist, analyzes biological information, and constantly adapts its own behavior, even recognizing monitoring malfunction. So in order to facilitate its operation, the patient is connected to several advanced biological sensors, and demographic information such as age, weight, height, sex, and type of surgery are entered into the system, so that the machine will automatically take all these parameters into account and adjust the dosage of the drugs. So MexLP has also has the ability to store and learn surgeon and anesthesiologist specific preferences through incorporated artificial intelligence technology also. So the future is going to be quite automated in every aspect of anesthesia and surgery. Now already we have robotic systems to intubate, robotic surgical items are there. So the future is going to be like this. So it is going to learn the surgeon and anesthesiologist preference also using artificial intelligence. And MexLP uses the mathematical algorithm of closed loop programming, like what is called LabVIEW developed software, to monitor and dose the anesthetic agents. And as a fail-safe, in the event of all machines, however much we formulate and market it, there are chances that machines can fail. So in that situation, anesthesia providers are able to override the system and revert to manual control of anesthesia administration. So that facility is also given in the MexLP machine in case something goes wrong. And major benefits of advanced patient monitoring and more accurate dosing are, this is the major benefit of closed loop system. Advanced patient monitoring is done and it's more accurate dosing can be given. Added advantage are the system will free the anesthesiologist from time consuming burden of monitoring. You have more time to watch in your WhatsApp and managing the administration of intraoperative agents. MexLP's program is loaded onto laptop connected to managers and infusion pumps and supports the usage of interface similar to the current anesthesia delivery system. And the system is more visible and reduces the fear of unknown device or a black box like thing that happens in the airplanes. And it may integrate Wi-Fi and mobile technology also in future. And system gives the operator the ability to monitor the patient's progress and drug dosage from any location via a portable drug adjuster. So this is the picture of what is you are going to see, the closed loop system. So these are all the infusion pumps which are going to administer the drugs, and this is the regular monitor, and this is the other monitor which will go into this incorporated into all this brain and actuator and all those things. So clinicians will be able to monitor several patients simultaneously via a remote or central local location. So in countries where there are shortage of qualified anesthesiologists, this system will replace the nurse anesthetists who are now humanly doing the things, especially in the United States. It's very common to have what is called nurse anesthetists who also have equal knowledge like anesthesiologists, but they are not considered as a consultants, but they are trained in proper anesthesia, airway management, everything. So instead of that, if you can produce machines that will take care of the shortage of these personnel. So in future, this may prove to be highly beneficial in countries that lack access to skilled anesthetists. So that is about the closed loop anesthesia systems. Now the next question in the current paper was advanced airway imaging techniques. What did you write?
So we
Those who have
vaguely
written-
wrote about CT, MRI, virtual CT, ultrasound.
LCT, ultrasound. Okay. So these are all the things that you have to write. So flexible nasoendoscopy. A narrow endoscope used to visualize the larynx, pharynx, and nasal passages. This technique can determine if the patient is a candidate for facial mask or ventilation or laryngoscopy or endotracheal placement. It can also be used to assess the status of vocal cords before thyroid surgery. So this is one of the important indications for flexible nasal endoscope. And this is, I told you in the class on thyroid surgery, that it is mandatory that we document the status of vocal cord before we take them up for surgery. And this is the picture of a nasal endoscope, and this is how It can be directly seen through the visual eyepiece, or it can be seen in the monitor by inserting it under topical anesthesia. We can see all the structures. Then there is a virtual endoscopy, which uses CT or MRI images to simulate the view of flexible nasoendoscopy. The next is ultrasound, a non-invasive real-time imaging technique that can help identify airway anatomy, assess the airway before intubation, and confirm the placement of endotracheal tube. Then computerized tomography, MRI. This technique can provide precise anatomic information about the upper airway and surrounding soft tissue surface. Dynamic and state-dependent imaging. This technique can study how the upper airway's bony and soft tissue structures change during sleep, respiration, and airway closure, just like what we do during obesity for overnight somnography. So that is about the next thing is core links in comprehensive cardiac support, cardiorespiratory resuscitation. What are the core links? How many links are there? Any idea?
6
Six.
links.
So early recognition and management of pre-anesthetic arrest, early recognition and activation of code blue, early high quality CPR, early defibrillation, early comprehensive life support post resuscitation care. So these are considered as the core links in adult cardiopulmonary life support. Whereas comprehensive cardiopulmonary life support algorithm, step-by-step procedure for resuscitating patient in cardiopulmonary arrest. What is the algorithm for that? The question was this comprehensive cardiopulmonary life support and the what do you mean by high quality CPR? Isn't it? The first part of the question was that. So the algorithm that you have to perform is this. This is the whole thing that is called the comprehensive cardiopulmonary support, life support. To ensure safe place, check response. First, always call the patient. Hello, are you all right? Loudly, tap on the cheek, see whether the patient responds or not. So once he is not responding, then we go through all the algorithmic steps of what to do, whether pulse is present or not. Immediately start. Earlier it was airway breathing circulation. Now, what is the change?
CAB.
CAB, circulation. So start with compression. Holds, compression only left support. This is the common thing for public as well as medical personnel. So start with compression, 30 compressions and 2 breaths ratio. So 5 cycles of 30 chest compression and 2 breaths. And feel for carotid pulse. Then attach the ECG monitor and see whether the shockable rhythm is there or not. Then activate the defibrillator. Shockable rhythm is shock, non-shockable. You just continue with the compression and breathing. Okay, so that is what the algorithm says. So quality of this thing depends on 3 things. One is chest compression. Should the compression speed, rate, and recoil ensure that chest compression speed is 120 compressions per minute, and the depth of compression should be 5 to 6 centimeters. Every time you press the external edge, it should be compressed for 5 to 6 centimeters, and allow complete recoil of the chest between compressions without lifting the hands from the chest. At the same time, do not lean on the patient's chest. Do not stop chest compressions unnecessarily. And these are the 3 things regarding the chest compression. And coming to the ventilation and airway, do not unnecessarily interrupt chest compression for securing the airway. Do not hyperventilate the patient once you have secured. End point of ventilation is visible chest rise after normal tidal volume breath. So these are the things that you have to keep remember. And monitoring end tidal capnography If it is less than 10, then the quality of CPR is inadequate and needs to improve that. So if it is more than 10, that means we are doing a good job. If intra-arterial pressure monitoring is available or feasible, then the relaxation phase of less than 20 millimeter indicates inadequate chest compression and needs improvement. And causes of cardiac arrest. This is commonly asked even in the ASCII. I think today Anjali had sent me the ASCII questions, and there is a question on this particular cardiac pulmonary resuscitation, and the causes of reversible cardiac arrest is asked in that also. So normally the 5H and 5Ts is the algorithm and the mnemonic that we remember. But here, one book I found that it has additional 2. Pick the target as a mnemonic. So you have 3 plus 3 plus 6 is 12 conditions. Of this, H stands for hypoxia, I for acidosis, increased hydrogen ion, T for tension pneumothorax, the other T for toxins, H for hypovolemia, E for electrolyte imbalance, then the other T for tamponade, T for, A for acute coronary syndrome, which is not usually included in the 5H and the 5T's mnemonic, R for raised intracranial pressure, which is also not included in the normal 5H and 5T mnemonic. B glucose, hypoglycemia, hyperglycemia, this is there in the H. E for embolism, that's also there, and T for temperature hypothermia. So the 2 things that have been added to the normal 5H and 5T causes of reversible cardiac arrest are, one is ACS, another is raised ICP. Okay, these 2 also are causes for that. And the rescuer performing compression must rotate approximately every 2 minutes to ensure high quality CPR. And so these are the things that have to be written for high quality CPR. One is about the cardiac compression, second is about the ventilation in the airway, and that causes of reversible cardiac arrest I just included just for the sake of remembering the allied answer. Now, perioperative point of care ultrasound. This also has been asked. Okay, so I think all of you have written this well because it's a very commonly done thing. Where all we use ultrasound in the perioperative, that is, it can be pre, intra, or post-op. Perioperative means we can use it in all the 3 situations. Airway ultrasound is used for endotracheal tube placement and confirmation, as well as visualize the cricothyroid membrane for emergency cricothyroidotomy, and it is helpful for analyzing or visualizing anatomical structures, and there is for airway nerve blocks or for awake fiber optic intubations. And because there are other so many things that we can use, but in the exam, these 3 important points you have to write so that I'm not doing the entire gamut of usage of airway ultrasound, like assessing the subdental space, cricothyroid, cricoid ring size, all those things are assessment in the pre-anesthetic state to facilitate, and that is given in one word as endotracheal tube placement and confirmation. Then cardiac ultrasound, it can detect valvular abnormalities, biventricular function, pericardial tamponade, volume status, and cardiac ischemia. And the utility of focus is invaluable in perioperative settings and attempting to make decision on whether a patient presenting with low exercise tolerance and unknown cardiac history will require further cardiac evaluation or not. So it can be used as a tool. And cardiac focus will reliably demonstrate ventricular wall hypokinesia, akinesia of acute cardiac ischemia, especially in situations where intraoperative EKG is normal. Sometimes, the EKG tracing that you get in the monitor may not be normal, but clinically patient may show a sudden hypotension and not respond to vasopressors. In that situation, definitely cardiac focus will help in finding out the hypokinesia that is happening before the patient visibly demonstrates ECG changes. Then pulmonary ultrasound is useful to evaluate causes of hypoxia like pleural effusion, pulmonary edema, pneumothorax, atelectasis, or bilateral inadequate ventilation. Gastric ultrasound will be useful to assess the volume in a fasting state to see whether there is a risk of aspiration or not. And the critical volume of 0.8 ml per kg. This is a value that you can use it to helping better determine the aspiration risk. So that is the volume that has to be accepted. Then vascular ultrasound can use it for central venous access, peripheral venous access, and arterial access. And ultrasound guided vascular access provides numerous benefits like visualization of target, reduced venipuncture, reduced risk of accidentally accessing an unintended artery, and anatomical variations and avoiding thrombus veins. And it's also correct used to differentiate between the venous and the arterial vessels. So by using the probe, you can press and compress the vein, but artery will not get collapse, will not collapse under that. So venous vessels are easily compressible compared to arterial vessels. Colored Doppler also serves as a useful tool to differentiate between venous and arterial vessels. And arterial vessels demonstrate a pulsatile flow on colored Doppler, whereas venous vessels demonstrate a continuous flow. And both Trendelenburg and Valsalva will increase the diameter of tubular veins with minimal changes in the site of carotid arteries. So that is one other technique that you can follow to identify IJV correctly. And vascular ultrasound helps to identify deep venous thrombosis also. So these are all with regard to vascular. Coming to regional, it can be used for peripheral nerve blocks, and it can be used for identifying the sinus process phase in obese individuals. And ultrasound as a valuable tool for hemodynamic monitoring in the setup of postoperative. You can track cardiac activity. You can assess hemodynamic disorders by a reliable method of assessing that, and it can help in interventions and monitor response to therapies also. And it can predict stroke volume response. Doppler ultrasound of left ventricular outflow can assess the output in real time and assess liver congestion. Pulsatile the index, the portal vein pulsatility index can quantify the flow through the cardiac cycle, and it can IVC examination can be used to assess volume status. Okay? So these are all the indications for perioperative ultrasound. This is another way of answering that question. So key technique, you can use it as a preoperative, intraoperative, or postoperative based on cardiovascular indications, volume status, pulmonary airway, abdominal and pelvic. So this also can be incorporated in your answers. And this is a picture to show another important thing in optic, especially in neurosurgery. You can do the ICP monitoring as well as the optic nerve assessment. Right, you need to see the ICP level, and in the airway you can do the ET tube location. In pulmonary you can do the pneumothorax, diffusion, airspace, cardiovascular, ventricular, alveolar, etc. And of course, in the periphery vascular access, abdominal, gastric volume, free fluid, and bladder volume. So this picture will give you a little idea as to what to write about the focus. And there was another question called prehabilitation. Can anyone of you tell me what are all the things you wrote in prehabilitation?
Sir, it is a team approach of physiotherapy, nutrition, physician to increase the functional capacity.
Very good. More importantly, psychological stability of the patient, because every patient coming for surgery will be having some amount of fear and anxiety, isn't it? So, good psychological preparation will make them more cooperative and more stable. Okay, so the purpose of rehabilitation is to withstand post-operative inactivity and decline and improve their quality of life. That is the purpose. What are the components of that? Medical optimization, physical exercise, nutritional support, and psychological preparation. These are the 4 things that are required or done in rehabilitation: medical optimization, physical exercise, nutritional support, and psychological preparation. The benefits of doing rehabilitation can reduce complications, shorten recovery time, and improve quality of recovery. When it happens after the surgical consultation and before surgery, usually over a period of 6 to 8 weeks, you do that. Especially for major surgeries which are done electively, rehabilitation for 6 to 8 weeks will help. And it can include exercise, high intensity interval training. Strength training can help improve functional capacity. Two frequently used tests are the cardiopulmonary exercise testing and the 6-minute walk test. These are the 2 things that are done to assess the status of functional capacity of the patient. And how to optimize that exercise intensity? It is by heart rate monitoring and using the Borg scale. Any idea what is this Borg scale? Rita, Risha, Vika? Yeah.
No, sir.
No idea. Okay. It is the patient's feeling of breathlessness. Yeah, I'll show you what are the components of that. So these are the 2 things that are used to assess the optimization. Then smoking cessation and alcohol reduction, weight reduction in case of obesity, all can be done by rehabilitation counseling. And stress is an amplification, and it can be reduced by well-designed programs which are included in the rehabilitation. Management of anemia, control of blood glucose, optimization of pharmacological therapy are also addressed as part of comprehensive rehabilitation program. Okay. Coming to nutritional support, a dietitian or a nutritionist can help in deficiencies and ensure adequate protein intake before surgery. Preoperative carbohydrate loading, which reduces insulin resistance and promotes anabolic state, minimizing loss of protein, lean body mass, and muscular function. Then coming to the last part of the psychological preparation, to reduce psychological distress and anxiety associated with the diagnosis of the surgical condition and surgery. It will maximize patients' motivation and empower them to comply with exercise, nutritional programs, and also be not so much afraid about the surgery and the anesthesia. Now, ADA guidelines of the management of unanticipated difficult airway, that has also been asked as a question in that. So all of you must be aware of this particular 4 steps in the guidelines. They always call for help with a very important component of that. The first step all of us try to do is induce the patient, relax the patient with a relaxant, and try to do a scopy and intubate the patient. Okay? So if succeed, you confirm the tracheal position using capnography and proceed with the anesthesia. But problem comes when you are not able to intubate the patient. That results in failed intubation. Then you do resume mask ventilation with 100% oxygen. And the second step in the algorithm is to try to insert the SAD. That is, after 3 attempts which have failed, you go for insertion of supraglottic airway and try to ventilate the patient. If you are able to succeed, and if you think surgery can proceed with the same LMA, it's a short procedure, not opening the abdomen, it's some superficial procedure, then you can proceed with the LMA ventilation itself and complete the surgery. But if it is a prolonged surgery where it is going to be a laparotomy of longer duration, and you want a secured airway in the trachea, then better to wake up the patient and plan for other alternative methods of securing the airway. And if you fail to ventilate the patient even with a supraglottic airway device, then go back to mask ventilation. Because we have successfully mask ventilated the patient, you can go back to mask ventilation, which will be more easy to maintain. And if you succeed to go ventilate the patient with oxygen and try to wake up the patient until he gets back his power. Or if you are not able to ventilate also in this situation, then you go for complete ventilation failure, where you have to go for emergency catheter. These are the 4 steps that you have to remember in the All India Difficulty Airway Association guidelines. There was another question called high flow nasal oxygen or high flow nasal catheter. Did you all write? What did you write for this? Because the answers that are given.
We mentioned about the high frequency ventilation, sir. In the theory, what behind that, the Taylor's distribution and then.
But here, this high frequency nasal oxygen given by cannula or high frequency oscillatory ventilation is something different, isn't it? That is called HFOV, high frequency oscillatory ventilation, isn't it?
Yes, sir.
I think the question was high frequency nasal oxygen, isn't it? HFNO. Okay, right. I want to discourage you by saying that. So it takes gas, able to heat it to 37 degrees with 100% reliability and can deliver 0.21 to 1% fraction of inspired oxygen with the flow rates up to 60 liters per minute. So that is the way it's called high frequency nasal oxygen. Flow rate and FiO2 can be independently titrated patient's flow and FiO2 requirement. And the main obvious benefit of high flow nasal cannula can deliver very high flow rates of gas to match or exceed patients' inspiratory flow demands. So there is a aspect of what is called peak inspiratory flow. Whenever we breathe, the initial inspiration makes the travel of air from the nasal passage to the alveoli at a particular speed. That is called the peak inspiratory flow rate. So unless the ventilatory support matches that peak inspiratory flow rate, gases will not reach the alveoli. They will stop short at the major bronchi or the non-ventilating portions of the lung. So that is the reason why we should always aim to match the peak inspiratory flow rate so that the gas or the air will reach up to the alveoli. So this high flow will also help in creating a heat effect of 1 centimeter for every 10 liters of flow with a closed mouth breathing. So this heat will also help in pushing the oxygen down to the lower alveoli. And when you give this oxygen to the patient, the FiO2 changes from the room air percent 21% with the amount of oxygen that is delivered, which is used calculated by 1:4 rule. That is 1 liter of per minimum of nasal cannula should deliver 25%. If you increase it to 2 liters, it will become 29. If you increase it to 3, it will become 33, like that. So for every 1 liter increase, the FiO2 will increase by 4%. So to deliver high amounts of FiO2 effectively to a patient, patients need ventilation and inspiratory demands need not only to be matched, but also it should exceed minimize the oxygen dilution. So the advantages of this HNFO are remembered by the mnemonic high flow itself. H stands for heated and humidified gas is going. I, it meets the inspiratory demands. F, it increases the functional residual capacity. L, it is a very light and portable equipment. O, it minimizes oxygen dilution, and it causes washout of pharyngeal dead space, thereby removing the carbon dioxide. So these are the advantages of HFNO or high flow oxygen. And adult indications are acute hypoxemic respiratory failure, post-extubation failure like low risk and re-intubation. It can be used for pre-oxygenation prior to intubation also. Patients who do not, who are already given do not resuscitate or do not intubate orders, then we can use this. This is not against the law to use this because you are not putting a scope or intubating the patient, just giving the supplementation with the cannula is an acceptable thing even in patients who want not to be resuscitated. Then cardiogenic pulmonary edema also sometimes we respond well to that because of the PEEP effect that you get with the high flow of oxygen. The pediatric indications are bronchiolitis is the only indication. Contraindications to HFNO therapy are same as non-invasive ventilation delivered via face mask or hood. Should not delay mechanical ventilation in those with severe respiratory failure, particularly in type 2 respiratory failure where there is hypoxia and hypercarbia. Any contraindication to application of PEEP should prompt alternative methods of respiratory support. It should not be used in those with reduced levels of consciousness or uncooperative patients. And in patients with epistaxis, facial injury, or airway obstruction, it should preclude the use of HFNO. Then there was a question on PICO, along with the hemodynamic variables and the parameters that you monitor for hemodynamic stability. There was a part of question on PICO. Did you all write that well?
Yes, sir, somewhat.
Huh?
Yes, sir.
Also slightly. So what are the components of PICO? What are the things that you need to do with pulse index contour cardiac output monitoring?
Sir,
How is it done practically? What are all the, is it invasive or non-invasive?
invasive.
Minimally invasive, that's what they say. But you, you are putting,
It is
what are all the
invasive.
invasive lines you are putting?
A central line, thermistor, and
Central line you are
radial
putting,
artery can
and the femoral
for
or
the
a radial artery cannulation, isn't it?
for
So
the
we are
pulse
calculating
counter
both the venous system as well as the arterial system
arterial
for
system.
PICO. Okay, and they call it as minimally invasive because we are not going through the branches of pulmonary artery like a PSC catheter. So that is the reason why they call it minimally invasive, but it's still quite invasive, and that combines pulse contour analysis and transpulmonary thermodilution technique. Description: catheter is an arterial line with a thermistor on one end. It's a pressure transducer, and there is a PICO monitor. So this is the picture of that. What you can see. You can see it is actually PICO catheter is inserted into the arterial side. Okay, it has got two lines, one going to the monitor, another going to the transducer, and the drain transducer is connected to the neckline, venous line also. And method of insertion and use are: insert a central line, place a PICO into large arteries like axillary or femoral, and attach PICO via pressure transducer to the pressure monitor, PICO monitor. Enter patient details prior to calibration. Administer a known volume of cold normal saline via central line injection port. PICO detects temperature difference and generates a dissipation curve to which the Stewart-Hamilton equation is applied to calculate the cardiac output. That is the mechanism of its working. And other measurements that can be generated are arterial BP, heart rate, stroke volume, systolic vascular resistance, and cardiac index. The thermodilution calibration technique, cold or room temperature saline bolus is injected, measured by arterial thermistor. Temperature change versus time plotted. And parameters that can be derived through that are cardiac output, cardiac index, global end diastolic volume of all four chambers can be detected, and global ejection fraction, ratio of four strokes volume divided by the global end diastolic volume, which can detect ventricular dysfunction. And another important thing it can measure is the intrathoracic blood volume. It is volume in the heart as well as in the pulmonary vessels, and the extravascular lung water contents in the lungs. Now, arterial pulse contour analysis parameters which can be derived are pulse continuous cardiac output, stroke systemic vascular resistance, stroke volume variation is sensitive to heart cyclic changes in preload induced by respiratory movements, and DPmax, slope of pressure versus time trace, closely associated with contractility of left ventricle. Now, central venous oximetry also can be measured using this measure of central venous oximetry, and that is also displayed continuously. What are the advantages of PICO? The transpulmonary thermodilution, with right-sided thermodilution only, less invasive compared to pulmonary artery catheter. Dynamic continuous monitoring measurement can be done, and also measures extravascular lung water, can stay in patient up to 10 days, unlike PA catheter which is used only for 72 hours. So it is more useful for patients in ICU who are hemodynamically unstable. And though no need of taking a chest X-ray to confirm the position of the catheter, and it is claimed to be cheaper, patients usually already require a central venous line and arterial line will benefit from that because we are using that for monitoring. And intrathoracic blood volume and global end diastolic volume are better indicators of preload CVP and PCWP, and it is not affected by mechanical ventilation. That is the biggest advantage of that. And extra volume lung water shown have a clear correlation with severity of ARDS, and number of ventilator days, and ICU duration. After the disadvantages of PICO cannot be used when there is a need for usage of intra-aortic balloon pump, and should be recalibrated with changes in position, therapy, or condition to account for compliance of vascular blood. In obese patient, this EVLW underestimates the related weight of the patient, and it can only be measured EVLW part of the lung perfused, underestimated in post-pneumonectomy patients. And the aortic aneurysm raises EVBB and ITBB, and severe AR may result in inaccurate thermodilution washout curve. So these are the things about PICO. And epidural morphine pharmacokinetics. That was another question. Did you all write that question well?
Yes, sir, we have written, sir.
What are the things that you mentioned in that? Is the pharmacokinetics like a regular intravenous administration or something different?
Sir, hydrophilic.
The hydrophilic character. What is the mechanism? How does the epidural morphine produce pain relief?
Level of spinal and at the level of supraspinal receptors.
What receptors? Which receptors are activated?
Mu receptor.
Mu receptors. Yes, it is a mu receptor agonist. Okay. And mu receptor, what does it do? How does it act? Is it an inhibitory receptor or an excitatory, stimulatory receptor? It's a G protein coupled receptor.
Receptor, yes, sir.
Receptor. Okay, so mechanism of action binds to the mu opioid receptor through distributed throughout the central, peripheral, and various nervous systems as well as various peripheral regions. Specifically, CNS mu receptors present in various crucial regions, including cerebellum, cerebral cortex, brain, putamen, all these areas that is there. Receptors located in the peripheral nervous system that contribute to analgesia are present in the dorsal root ganglia. And it binds the G protein coupled receptors, initiating intracellular transduction pathways, inhibiting adenyl cyclase, stimulating potassium efflux, and inhibiting calcium. So consequently, these changes reduce intracellular cyclic adenosine monophosphate, causes cell hyperpolarization, and inhibition of neurotransmitter release. That is the mechanism. Now, pharmacokinetics. On pharmacokinetics is ADMA, absorption, distribution. So morphine administered via epidural space is absorbed into the systemic circulation. Even though we are administering extravascularly, ultimately it goes into the circulation. So peak plasma concentrations are reached within 10 to 15 minutes, whereas peak CSF concentrations are achieved within 60 to 90 minutes after injection. Distribution with CSF concentration is significantly higher than plasma concentration, and specifically CSF concentration accounts approximately for 4% of the epidurally injected drug. And the efflux of morphine from CNS is influenced by the ABCBI, a member of ATP binding cassette transporter family. So this is how it is removed from there. And metabolism, the clearance pathway moves hepatic glucuronidation. Same thing is done. 1 second. Hello. சார் சொல்லுங்க. சரி. ஆமாம்மா. பீரியட் சரி சரி சரி. சரி வெயிட் பண்ணி பண்ணுங்க. ஓகே ஓகே. சரி சரி சரி. மண்டே பண்ணிக்கலாம். சண்டே சொல்லுங்க சார். எனக்கு சண்டே வேற ஏதோ ப்ரோக்ராம் இருக்கான்னு தெரியல. நான் கன்ஃபார்ம் பண்றேன் உங்களுக்கு. ஓகே ஓகே ஓகே. சரி சரி சரி. ஓகே ஓகே. சரி சரி. சாட்டர்டே எடுத்துக்கலாம். அவங்களுக்கு தான் டிஸ்கஸ் போட்டோம், நமக்கு ஒன்றும் இல்லை. ஓகே சார். நமக்கு ஒன்றும் ஓகே. சரி சார். ரைட். ரைட் சார். சரி சரி. நான் கிளாஸ்ல இருக்கேன், நான் பேசுறேன் சார். ஓகே ஓகே ரைட். So this is the same mechanism how it is eliminated from the hepatic route, and the excretion half-life is 39 to 249 minutes. That is how it is able to work for a long time. And it metabolized primarily excreted via kidneys, approximately 10% administered and eliminated in the feces. Epidural morphine can be administered either as a single bolus or through continuous infusion. And it exhibits a slower onset of analgesia but longer duration of action because of the hydrophilic properties. What Sanjita mentioned about hydrophilic property is this is what we have to consider. And the dose of epidural morphine is lower than intravenous dose because of good spinal cord selectivity. Epidural morphine approximately 5 to 10 times more potent than intravenous form. It is commonly administered at doses of 30 to 100 microgram per kg and the continuous infusion of 0.2 to 0.4 milligram per kg. Caution needed in using epidural morphine in patients who have hepatic renal impairment or pregnancy and breastfeeding women and pediatric and geriatric age group patients. And the drugs which have an interaction with morphine are MO inhibitors, the other SSRIs and SNRIs used in psychiatric treatment. And it also should not be used concomitantly with the agonist antagonist drugs like buprenorphine and cetirizine, which can reduce the analgesic effect. And it can produce withdrawal syndrome also. And morphine can delay the action of clopidogrel, which is a T2Y12 inhibitor, thereby delaying the onset of their antiplatelet effect. So patients who are on clopidogrel, this can cause an interaction. And concurrent administration of morphine with anticholinergic drugs like atropine or glycopyrrolate can cause urinary retention and paralytic ileus. And contraindications for use of epidural morphine are patients who have respiratory conditions like COPD, bronchial asthma, upper airway obstruction, and also patients who have a history of allergy or hypersensitivity, and absolute contraindication for neurological anesthesia, including coagulopathy, infection, sulfite, uncontrolled bleeding, etc. So that completes the theory question discussions. So some of the questions which I thought have been asked for the first time, I thought this will be useful. This will be repeated for the next batch of students. Okay?